Oh, hey, Chris.
Hey Chuck, how are you?
It's a Saturday morning. I'm talking to you. What could be better?
Well, it's about 40 degrees warmer than the last time we talked, which is super weird. But it's in the middle of November, towards the end of November, and somehow it's 72 degrees in St. Louis. No idea what's going Fahrenheit. Again, no idea what that is in Celsius. It's warm though.
I am excited because it's been the entire week has been beautiful and it's gradually gotten warmer and warmer. And I haven't been able to appreciate it with dark, it's one of we're already to the dark when I go to work and dark when I come home from work. So I'm looking forward to today. We're recording on a Saturday to Saturday and Sunday.
Yes, get outside a bit. I've been sprung into some extra parental duties. This is the classic kind of your kids are in this age. When my daughter is 7, my son is 10. So today, my daughter's going to figure skating because, of course, now we've picked up a new sport, which is awesome, and she loves it though. She's great. And my son has a friend over right now for our play date. We're all going to convene for lunch after I have done this, worked out, gone to the grocery for the week. We'll have lunch. I'm going to take the kids rock climbing, which they love to do, and it's a nice way to kill some time. And then I think we're going to meet up. My son has a hockey game, the third of 3 games this weekend. And then after that, we're going to go to the Blues hockey game. So it's just nonstop, but in a really fun way. There will be a lot of really fun times today. Hopefully, I can find time to take a breather from all that.
That is a lot, and it's also a lot of ice time.
It's crazy. I mean, so my wife and I are both Filipino American, and so, we're island people at heart. I grew up in Florida
Your
and
genetics.
I grew up in Florida, she grew up in Texas. So the fact that both of our kids have adopted ice sports is something else. So it's an adjustment, but it's fun. I mean, I don't know much about hockey. I've picked up a lot along the way, but I'm learning, so to say. And then
I
I know even less about figure skating.
Thankfully, our generational divide is evidenced by last weekend. I went to see my youngest, my only one still in college, and it was sorority dad's weekend. And
Wow.
all I can
Don't even
say
put that
is,
thought in my head.
yes, it was fantastic, and it was fun to see your friends and interact. And all I can say is I'm grateful I'm not a sorority dad. I mean, I'm not a fraternity dad because I don't think
Ah,
I could have survived the weekend.
yes,
It
that
would have
probably
been
would
a
have had a
lot.
different flavor of weekend.
Yes, but very fun, very fun.
So we have a couple of interesting things to talk about today. We have a great listener email about a common thing that all of us surgeons and therapists treat, trigger finger. So we'll go to that, and we're also going to combine our interests, so to say, and talk about some of the technical details of Guyon Canal release and hook a hamate fracture treatment. So that should be fun.
Oh, it's great. It's a great topic and very pertinent to most of us. And I think some technical pearls and considerations will be helpful. But first, Chris, let's thank our sponsors.
The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job does not have to be. Join Practice Link for free today at www.practicelink.com slash, not backslash, slash the upper hand.
I was listening to a different podcast and they very much went out of their way to say forward slash. So I'm not saying that I was proven right, but
You were
somebody
proven
else
right.
was proven wrong. So not a backslash. I'm glad we picked up on that. I don't want people putting the backslash into their browsers. Who knows what happens?
Who knows? Yes, scary stuff.
So we had a great email from a surgeon who's new in practice, and they had some questions I think that are really useful. And like Chuck, I'd like to get your thoughts on this. I've been thinking about it quite a bit and asked for some opinions too. But this surgeon is a little over a year into practice, has been listening to the pod since fellowship, and has enjoyed listening to us present interesting topics in a fun and engaging way. Well, thank you for that. The question is, what is the secret for a successful trigger finger surgery? Most of my patients end up stiff, and some patients also have some element of contracture at the PIP joint. Most of my patients are elderly. I do almost all of the trigger finger releases Walland. I use an oblique incision. I do release part of the A2 pulley and make sure in the OR the patient has full range of motion and no catching. What am I missing? Do you have any pearls for getting optimal outcomes after trigger finger surgery? So, Chuck, I'd open it up to you. I've thought about this quite a bit because, I think this is something that all of us kind of come up against. But what are your thoughts about just in general about the topic and then maybe some technical pearls?
It's really we've talked about this a little bit. I'm glad this is a question. if you read the literature, and there's actually been some literature recently on this, the suggestion remains that the vast majority, 95% plus, do great. And that's not my lived experience. And yes, the vast majority do well. I just don't think it's 98%. Um, and
Well,
some
define, I guess, define do well.
do well is have your surgery, recover from the incision, and within 3 to 4 weeks have no pain, full motion. And scar tissue development is real and it happens, and limited motion is real and it persists. And revision, the need for revision, i.e., because of triggering, is less common in my experience. But unsatisfactory outcomes happen. And to me, there's a couple factors. Number one, it is patient factors, timing of presentation, associated diabetes, age, chronicity, all of those affect outcome. Um, I don't know if it's the technical part, but I'm interested in your thoughts.
How do you think the diabetes plays a role into it? It's just like a general wound healing kind of thing. Like, how does that, I know the literature says that, but I will indicate somebody for a trigger release, whether or not they're diabetic. I guess if I find out that their A1C is crazy high, then maybe I'll ask if they hold off. But, again, it's not under any sort of general anesthesia or sedation.
Yeah, I don't know how diabetes plays a role. I mean, we certainly see diabetics who are just stiff.
Hmm.
The older patient who has longstanding diabetes, typically insulin dependent, and just has stiff fingers. Does that somehow or another affect or negatively affect a trigger finger outcome? I'm not sure.
Yeah, I guess I've thought a lot. We can get into the technical parts, but I think I've thought a lot about this because, I guess that, by and large, most of my patients with this condition who have surgery end up doing well. I will also say most of my patients who have this condition don't go on to surgery. Um, I, I don't, I'm not shy in offering injections until, everybody's frustrated with the injections not working. But usually after, and I don't know how to say this properly, after 2 or 3 injections, either the triggering goes away or they go away, or it doesn't bother them enough to come in, or they see somebody else. But and I tell them like once we've kind of run that course, then we consider surgery. But maybe that plays into the chronicity part of it. I mean, how many injections do you give before you're like, hey, let's move on?
So these days, my party line is I'm happy to give you an injection today. If in 3 months or 6 months or 9 months the trigger comes back, you have a choice. I can do a repeat injection, or there's a very simple local only surgical option. I will be happy to give you a second injection. I don't give third, fourth, or fifth injections. And I'm not rigid about that. If someone asks for a third injection, I'm not going to say no. But that's my party line. And I think it's mixed what people do. I don't think people are choosing to go to a different doctor for their surgery. So I think your experience is similar to mine. The vast majority of people don't need surgery.
Do you think your threshold to offer surgery has changed now that Willand has really at least swept in our practices within the last 5 years or so? But would you have thought harder about offering surgery if somebody had to have sedation?
For sure. It's such an easy intervention. And yeah, I absolutely have a lower threshold to recommend surgery. Not as a starting point unless the patient just wants it, but after a single injection, I feel very comfortable with surgery.
It's crazy, man. My grandfather was in his 80s and living in Florida and had a trigger finger and I couldn't find anybody to do Volant, which I thought was insane.
Oh,
So I was like, that's crazy. Like, this is the perfect population in which to do Volant. I mean, the nonagenarian trigger and carpal tunnel, if they really want surgery after you've kind of given them the riot act about, the risk of surgery, it's the perfect population. So in a way, it's lowered the threshold to make surgery more accessible to people in which it wasn't the surgery you were worried about. I mean, you worry about every surgery, but it was more the anesthesia and the sedation, et cetera.
yeah. It's as far as well, technically, I've done different skin incisions, and I'm convinced that doesn't matter a bit. Currently, I'm doing a longitudinal incision. What about you?
Why do you do a longitudinal incision?
It's easier and it's faster, and I don't think a transverse and oblique incision matters one darn bit from appearance to exposure.
Is it really faster?
I think it is. You,
Okay.
you want you want my spiel to the resident or fellow
Yeah,
quietly?
yeah, 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 yeah.
Yeah.
I'll try not to get triggered by this experience from fellowship days, but yes, please, please, please give me the spiel.
Longitudinal incision through the dermis and epidermis, very centrally located over the A1 pulley. Spread 3 times transversely with the tips of the scissors down on the A1 pulley. 2 Ragnell retractors going radially and ulnarly. A third, and the surgeon holds one, the assistant holds the second, and the assistant also holds either a proximal or distal send retractor. And you sort of scrape the soft tissues off the A1 pulley, providing perfect exposure for knife release.
Is
Is
it a
that
complete knife release or is it knife to start, scissor to finish?
Yeah, 80% knife, scissor proximally, scissor distally, very proximal A2 release, distal half or so of PA release, and
How
then
much A2? Like why just, a couple millimeters? I mean, how do you determine that? Like
until I clearly know with 100% certainty that A1 is released, and if there's any suggestion of tightness, a snip. I don't want to do too much. I can't quantify it more than that. Do you do anything to A2?
yeah. Typically, we'll release a portion of A2 on if everything is going well. You will release A1, and then you will see it just kind of spring open,
Yep.
which is ideal. And sometimes you do that, and then you go a couple more millimeters. But I don't release a ton of it. I probably go up to a quarter of it, just based on the generic number that we have of about the A2 being about 16 millimeters, based on a study that from decades ago that we quote that has since been updated and refuted. But I remember memorizing the numbers for anatomy, which anybody who's trained with us has the PTSD from that, and and then reading subsequent updated anatomic descriptions and being hesitant to introduce them into our anatomy sessions because I don't want people to think that I'm crazy because we've all memorized these numbers as sacrosanct. And, certain faculty roll their eyes at the numbers. Other people embrace them because they have other meanings. But anyway, so I guess I'll give you what I'd normally tell our residents and fellows. So I want to attribute this paper to Scott Wolf, but it might just be because it was in Green's operative hand surgery when I was reading it as a fellow. But I tell them to take the distance between, if you're looking on YouTube, between the palmar digital crease and the PIP crease. If you take that distance and extrapolate it back, that is where the leading edge of the A1 pulley is. And that was based on studies, doing percutaneous trigger finger release. So as
Absolutely.
much as I can, I make an incision right in that area to get me access to it. Now, if it happens to tuck really nicely into an existing skin crease, I will do that, even if it's just a couple of millimeters proximal to where I need to be, because I can mobilize the tissues to get there. I feel like it doesn't matter to most patients, but for some patients where they're like, "Oh my God, I can't even see my scar," they love that. So if you can get an easy win with that, get that. But I'll tuck it into the crease if I can. If not, I'll make an oblique incision, more transverse than longitudinal, with the exception of the index finger and the small finger, mainly because of the trajectory of the radial digital nerve for the index and the ulnar digital nerve for the small. They're just ever so slightly off. That I'd rather be a little bit more. It's still somewhat it's still somewhat oblique, but it's more longitudinal than transverse. It's crazy. It's way too into the details and the weeds than it probably needs to be. But I tell them, especially for the thumb, but for all the fingers, skin incision only through the dermis, so you can see basically start to see the palmar fascia. Like you, I tell them to take the tips. This is where learning how to use the tips of your scissors as an extension of your finger to feel becomes very helpful. Which backpedaling from just this, but I don't know how other surgeons operate, but I think our group, most of us are tips down with the tenotomies, whereas there are a couple of rogue people that are tips up. There should be a reason for everything. And I've kind of come to this in my mind. Nobody, when I was training, explained this to me, but I like tips down with the tenotomies because then I can feel with the tips of the tenotomies the tissue underneath me. And again, using it as an extension of your finger. Whereas tips up, you just don't get that same tactile sense. There are times where I go tips up, and usually it's during kind of complex neurolyses and that kind of thing. But usually I'm tips down for everything else when I'm trying to navigate through tissue. Anyway, so I will using the tenotomies as an extension of your finger. I will actually, instead of transverse, I'll have them go longitudinal on the tendon. Use the tips to park themselves in the center of the tendons, and then spread longitudinally with purpose, or depending on if they knew Dr. Gelberman, and I would say like a person, he would say things differently, but but with purpose. That is a purposeful spread longitudinally along the course of the tendons, ideally to open up that palmar fascia and expose that tendon. And as that spread is being held, those ragnells, like you do, get parked. But you've wasted three spreads transversely. I'm doing one spread longitudinally. Park the ragnells, and that exposes your A1 pulley. And if you place that incision the way you want it to, you are looking at the leading edge of the A1 pulley. The third retractor is the blunt end of the sen going distally to hold up the distal tissue to expose the rest of the A1 pulley. Knife to start, scissor to finish. Remind them that the scissors they're using at least are curved, so they need to adjust so that they're shooting between the goalposts and not drifting radially or ulnarly. And then turning around, and whoever's on the other side of the table releases the all of the PA pulley. And then I don't know how you do it in terms of the check. I check one. I have the patient actively flex and extend to make sure it's not triggering or catching. And then after I'm convinced of that, I will cover the wound with a clean Raytech, kind of tucked into the palm, and I'll hold it here like this, and then I'll have them take the drapes down, do the big reveal, and show it to them and make sure they agree that it's no longer catching.
Nicely detailed. I
I will
mean,
get off of my soapbox.
well, you got a couple things wrong.
The representative from Missouri will rest. I will cede my time to the representative from Clayton.
It is quite amusing to me that such a simple procedure can lead to such different approaches, even though they're not that different. So you have options, and I think both of those are essentially the same intervention, but slightly different techniques, and that's the beauty of hand surgery. And I don't think the technical descriptions have anything to do with the suboptimal outcomes. And I think our job as surgeons is simply to assure complete release, take care of the tendons, and minimize trauma during this intervention. And
Do you
otherwise,
visualize the neurovascular bundle? Because I've seen, unfortunately, I get stuff that comes in and you read other op notes and like I visualize the radial and ulnar neurovascular
no,
digital bundles. And that's the purpose of those Ragnells, right? So that's an
correct.
important thing that probably both of us stated that we didn't really unpack is that we're looking at the tendon sheath and parking those Ragnell retractors so as to get those and to retract those bundles out of the way.
Keep them safe. That's exactly right. Don't need to see them. I think there are, I was talking with a fellow about this recently. There are, I think at one point in my career, I kind of said, I don't need to see any nerve or artery anywhere. I just keep them safe. I think that is not appropriately stated. Certainly for trigger, I don't need to see anything. And then, like, flip it around when I do a CMC procedure, I think you can honestly try to avoid seeing the radial artery, but actually I feel better when I see it and know I'm retracting it. So I think there are certainly surgeons who want to see every neurovascular structure that is potentially in play. That is not my approach unless I am concerned about it and know that I need to keep it safe because it is truly at risk. It's not truly at risk with a trigger.
Yeah, and I would agree with that. And just to dive into what you talked about, I mean, I tell our trainees, about the dorsal branch of the radial artery and how if Goldfarb dissects it out, it must be important. So because everybody comes to my service and wants to dissect out everything, and I actually don't dissect out everything. But I was like, if Goldfarb thinks that this is important, then we need to dissect that out and protect it. But also, practically, if you're doing a thumb CMC from a dorsal approach, because of the trajectory of that artery, if you don't protect it and do a little bit of an arteriolysis, when you come around the radial or dorsal, or excuse me, ulnar or dorsal edge of that trapezium to do your trapeziectomy, you'll run into small little vena comitante or branches of the actual artery. And it's gonna be a pain in the butt. So you might as well identify it, mobilize it, retract it, get it out of the way so that you can finish your trapeziectomy with ease. Because I feel like that's probably the hardest part for some people is getting that kind of on the ulnar and dorsal edge, the radial and volar edge, and getting all the way around and releasing that, particularly at the STT, so that thing can get sprung out really easily. Anyway, so
Yeah. Maybe we'll thank our other sponsor before pivoting.
I do. But there's actually more I want to talk about with this.
Oh my
We
God, no, no.
Well, so I was thinking about it. So I don't think this listener's issue is technical, and it might just be a product of their population. Um, what I've evolved with in trigger finger is counseling and pre-op counseling. It's the one or two patients with the painful scar that will make you introduce into your counseling about the painful scar. It's the one or two patients who have persistent triggering, which theoretically shouldn't happen, but it might, that you will introduce. You have to counsel them about the adjacent fingers that potentially could be involved at some point, and they may feel like it's the finger that you operated on. And then the biggest thing is, I think, is the PIP contracture. And there's more literature coming out about how people with PIP contractures, tend to keep their PIP contractures, and that doesn't get better. And if you don't level with the patients ahead of time that this, the bend in your knuckle is not going to get better, and tell them why they have the bend in the knuckle, I would not expect any PIP contracture to improve. I just tell them I'm going to get rid of the triggering, but this has been there for so long. It's a marker of severity, as the trigger staging system. The PIP contracture is the most severe. It's not going to get better. Tell them that, and then also look for it ahead of time, which I'm sure this listener does, and all of us do. But if you look for it and point it out ahead of time, that messaging I think is helpful. And then lastly, actually, I have one more comment to make, but I want to see if you have anything to say about what I just mentioned.
No, I appreciate the comments. I think this cannot be emphasized enough. The preoperative conversation has to be not only talk through this simple operation, but emphasize and document other things that we think about in assessing outcome. You hope that the patient remembers everything you say. They may or may not. It is nice, especially in this age of the electronic medical record and patient access to it, to document those same things. Again, not even medical legally. Hopefully, that's not the point. Of course, it's the point, but it's a secondary point. It's just to have it written down that you talked about these things, you emphasize these things, with the understanding that not every trigger finger surgery provides a 100% back to baseline recovery.
Right. I think that's something where like we would think about putting in a note, but sometimes forget. But then when the AI tool puts it in there for you, it's helpful. I also think this is an advantage of Wallant surgery, is that, I can show them, hey, you're not triggering, but remember this bend in your knuckle is still going to be there. I'm not changing it right now. So it is what it is. And again, they're probably overwhelmed with a lot of stuff day of surgery. They're not going to remember what we talked about, but it's messaging before, during, and after, which I think probably is helpful. And then the last thing I'll say to this listener is I did ask one of our hand therapy colleagues, Jamie Findice, who she started working with me at the very beginning of my practice. So we've kind of grown up together treating patients. And I asked her what she thought the issue might be. And, because very rarely do I send somebody with a trigger release to therapy. So there's some bias in who they see. But she sees patients from other surgeons who routinely send, trigger finger releases to therapy. And that's a different thing to unpack. But one of the things she was saying was that it's just the same kind of person that you see them and you're worried how they're going to do after a carpal tunnel release. You see them and you're worried about how they're going to do after a distal radius fixation. Are they going to re-engage their fingers into life? And so that's not a perfect answer. It's certainly not objective, but I think if you've seen enough patients who are stiff after any sort of intervention or injury, you know that the look of that patient. And this is where the art and practice of medicine comes in, because those are the patients that you have to message really early on or steer away from surgery potentially. But I think there's also just this encouragement that you need to tell the patients to use their fingers after surgery, to move their fingers, not to lift anything heavy, but to actually make a fist. And at least I think your patients get the same handout, but a handout after surgery doing the 6 pack of exercises to curl down into a fist, do a hook fist, spread your fingers far apart, etc., and really empowering them and encouraging them to do that. Again, helpful wide awake surgery.
Yeah, great points. All true. All right, I can't talk about trigger
I,
finger
I, I was
anymore.
going to say, I don't think you can talk about it anymore. So why don't we, before we pivot to our final topic, why don't we thank our sponsors? Surgeons know Checkpoint Surgical for their monopolar nerve stimulator, Guardian, aka the blue one. But did you know they have a bipolar nerve stimulator called Gemini, also known as the purple one? With the bipolar stimulation probe, Gemini provides finely controlled stimulation even at the fascicular level and is an ideal stimulator for selective neurectomy for spasticity.
Want to know more? Visit checkpointsurgical.com. I know the blue and the purple one now. I thank you for adding those in.
I was
I'm
so
ex
impressed. So I did a case yesterday. We had a new partner join us, which is super exciting. David Wright's a former fellow, trained with us, graduated, I think, 2 or 3 years ago. They all blur together now. But excellent fellow. Excited to have him back to join us, and he's joining our nerve team. And we were able to get him to rearrange a schedule to join me for a plexus case recently, which was super fun to operate with a new partner. And I'm so used to calling them the blue and the purple, but he was calling them by their proper names, which I was really enamored by.
I too have seen Dr. Wright recently. We had an open house at our new office on Wednesday. So after the OR, I sped over there, but they started at 4:30, so all the local VIPs were there at 4:30 and I rolled in at 5:30 and missed it. But yeah, I'm excited. It's nice having his energy and his excitement being here.
Yeah, yeah. So I'm excited to see how how he wants to move his career forward and how we can support him in that and incorporate him into our nerve team as well as our general hand surgery team. So, welcome, David.
Yes. So, not that he's listening, he's probably had enough of us. But all right, what I think might be fun is I'm going to ask you what your indications are for a Guyons Canal or a distal ulnar tunnel release. And then I might, if you were to ask me, I might provide my indications
We might run out of
for
time.
we won't, I don't think, for a hook of the hamate excision. And then we can go into some technical. So, Chris,
So, are you asking me?
what are your indications for a Guyon's Canal release?
So I think that compression at Guyons Canal, I think, is hard to diagnose. I think it's more nebulous than we make it seem. So when you read the textbooks, we talk about the different zones of compression of Guyons Canal as described by Gross and Gelberman. Um, just as an aside, which I'm sure you're not looking for more asides right now, but I was talking about and Guyons Canal, and I was
What?
telling
Not the
the
man. Not the
no,
man.
I was telling the fellow Pradeep at Alluri, awesome guy, and we were talking about. I was like, you know who Guion was? And of course, he's like, no, why would I know that? I was like, so I barely know about it. So Guion was, and I told him, I was like, he's a French obstetrician, and that's kind of the extent of what I knew. And then we were talking about other, eponyms in ulnar nerve compression, as nerve nerds do. And so I started just like, I was like, I should probably learn more about Guion. So Guion was a French surgeon who initially was an obstetrician, then eventually a gynecologist, and then eventually switched over to being a urologist. But the reason why he is associated with this distal ulnar tunnel is that he noticed these like subcutaneous like fat nodules on the base of his palm. And his thought was they must be coming from underneath in this area, now known as Guyon's Canal. So he started to then do a bunch of dissections. Turns out that these subcutaneous nodules were nothing to do with nerve compression or anything else, but he's the one who originally described it. And then Emmanuel Kaplan, who is known in the English language as the godfather of anatomy of the hand in the upper extremity, then found Guyon's descriptions, and then it became known as Guyon's Canal. But
Wow.
the zone classification that we all use, at least in St. Louis, and I think a lot of people do as well, was described by Dr. Gelman, the first author, as gross. But anyway, that was fun fun knowledge to pick up.
And quickly, what are zones one, two, and three?
So it's based on the anatomy of the nerve. So thanks for bringing me back to earth there, Chuck. So in zone one, you've got the combined motor and sensory components of the ulnar nerve, and as the nerve continues across the base of the palm on the ulnar side, it will then split. Now we call them the sensory and motor branches, but technically that sensory branch does provide some motor innervation to the palmaris brevis if it is indeed present, which it's not in everybody. And then as the sensory component continues and then goes to supply the fingers, typically the small finger as well as the ulnar side of the ring finger, that is zone three. So that's kind of riding on top on the most volar aspect of the palm. But it will then, the nerve before then will split into a motor component too, which then goes deep, and that is what we call zone two. And as we've kind of learned more about the anatomy, the branch to the ADM itself, so the biggest one of the hypothenaurs may come off of that proper zone two branch as it goes deep to the fascia, or it actually can come off earlier than that. Closer to where it's, we call it the bifurcation. I've now started to call it a trifurcation. And that's helpful when you're doing a nerve transfer to really understand the anatomy of that. But the difference between the ADM branch and the deep motor zone 2 proper branch is that the zone 2 proper branch is going to head deep and head towards the middle of the palm, whereas the ADM branch will deviate and go towards the ADM muscle and take a more superficial course. So when you're stimulating a nerve in surgery, and you want to make sure that it's going into the ADM and it's not going in deeper and controlling the rest of your intrinsics. So you asked me about indications. I think it's hard to diagnose. I think that very hard to pick up on electrodiagnostic studies. If you pick it up, it's probably real, but oftentimes you'll have false negatives there. I think you get now into the dogmatic, when do you release it? Well, you release it when you think the nerve compression is severe, the ulnar neuropathy is severe. Now, I don't think you can get a good Tennell's here because anytime you percuss along the volar aspect of the distal foramen at the wrist crease, you're probably getting some scatter into the median nerve. But if you try Tennell's, more on the ulnar side and you get something classically into the small finger in the ring, then maybe that's real. I think a more controlled way is to do just apply direct compression or direct pressure, just on the inside or just on the radial side of the pisiform. So if your pisiform is here, just on the radial side of that pisiform and putting pressure there will pretty much compress your, at least your nerve at zone one. And then if they get classic paresthesias into the ring and small, then that's probably real and probably should be decompressed. But even I understand, I recognize the shortcomings in that because when we all do a decompression, we all think the money is decompressing zone two. So if the zone two is actually out here and I'm not pushing there, then what does that actually mean? So I think this is more of like a when do you decompress it? When you think the nerve injury is really severe or the compressive neuropathy is really severe and you want this to be the last thing done.
We had a conversation at our indications conference about this very question as it pertains to a coexistent carpal tunnel syndrome. And I was making the point that I feel pretty strongly about, and I'm curious if you do as well, that when one performs a carpal tunnel release, it has been demonstrated in multiple studies, MRI studies, ultrasound studies, etc., that the morphology and the volume of the cubital of the distal ulnar tunnel also increases. So release the carpal tunnel, you also enlarge the distal ulnar tunnel. True or false?
I think it's true. I mean, you see that when you do the release. If you're doing a combined carpal Guyon release, you'll see that. And I think that the beyond the studies that you've described, there are also studies using kind of subjective PROs and subjective just asking patients, not with validated PROs. But if you do a carpal tunnel release, a lot of times their ulnar nerve symptoms, if they're mild, will actually get better. And it's kind of weird to think about why that is. But you're getting an indirect decompression of zone three. Now, if your issue is zone two compression, zone two issues are different, right? Because that's controlling all the intrinsics. But if they are sensory issues, paresthesias, I do think you get decompression of zone three. And the reason I say that you can see it is that when you do a combined carpal Guyon release, at least I don't know how you do it, but the way that I do is I actually start with the carpal tunnel because I think it's a nice way to show the trainee or the learner with you how to recover from making an incision that's too ulnar. But the reason I really like it is that once I release my transverse carpal ligament, I can then use that to walk into Guyons Canal. So, because then you've got that radial or the ulnar leaflet of the TCL is the floor of Guyons Canal. So as soon as you just kind of ride along there, you no longer have to swim in all that fat. You basically retract, and this is where you let the palm kind of rotate towards you if you're sitting on the inside or the in the axilla. You don't want it to rotate towards you when you're doing a carpal tunnel release because then you're going to fall into Guyon's canal. But you want to take advantage of that when you're actually doing Guyon's canal release. Let it fall towards you, pull on your ulnar TCL, and then ride right into Guyon's canal. And then you spread, and now you're looking at the bundle. As opposed to before, you would either have to wade in all that fat and dissect it out, or you would have to cross the wrist crease in order to get a good starting point on the nerve. But you've got so much more space there after you've done your carpal tunnel release. I think it makes sense what you're asking about.
Yeah, and I don't do I don't do both procedures very often, and that was part of the point. I will do a carpal tunnel release, and if there's very mild distal ulnar tunnel symptoms or nerve changes, I will often not do it. And I certainly don't routinely do a distal ulnar tunnel decompression when I do an ulnar nerve at the elbow. Since we started talking technical, I will say one thing I feel very strongly about is I try really hard not to cross the wrist crease when I decompress Guyon's Canal or this ulnar tunnel because there are a few things that I have experienced with my patients more strongly than the dissatisfaction of that incision crossing the wrist crease. Do you feel similarly?
Yeah, they hate it. I mean, it's a similar point. Like if I'm doing a carpal tunnel release at the same time as a volar plating, I will not cross that wrist crease there, even though I know that that's probably that point of compression after trauma is that volar interbrachial fascia right underneath the wrist crease. So yeah, you work underneath the skin bridge. That being said, if you need to find what you need to find, you got to do it. But the scarring of that crossing the wrist crease incision that can limit motion and cause a lot of discomfort and pain. And I've seen that in my own patients as well. Conversely, you will see people who are incredibly widely respected in nerve, including our own Dr. McKinnon here at WashU, who will say that, you got to cross the risk crease. But I think the reason that she says that, so like you hear like these, luminaries talk about certain things, and then, I think it's important to try to unpack what they're saying and why. I don't think you need to cross the wrist crease. It's just you need to release the volar interbicual fascia that is kind of pre-zone one, right? And you
Yeah,
can release that pre-zone one fascia through the through the incision in the palm, but you just have to be very intentional and safe about it. And once you've seen your bundle in the palm, you can directly visualize that volar interbicular fascia, just like you do with the carpal tunnel release when you're releasing that fascia, and release it safely. It's just got to be part of your Guyons Canal release.
absolutely. And to be very clear, Chris and I haven't talked about this, but I'm pretty confident that we do not perform a straight incision across the volar wrist crease. We angle it 45, 50 degrees to minimize the scarring, but it just doesn't preclude discomfort. And just bear that in mind. Again, preoperative counseling.
Yeah, that zigzag, I mean, it's supposed to help with that, but it can be very, very uncomfortable. So, I try to tell people I mark out in holding. We've talked about this before. I kind of tell them where it's going to be. I had one patient, I was doing Bruner zigzags for like a dupes or something like that. And they were asking, I was like, oh, did your knife slip? I was like, oh, I should have told you ahead of time that we were going to do zigzags.
Oh, that's
But,
funny. What
um,
other what other technical pearls before, and we can talk about the hook of the hamate pretty quickly. What other technical pearls on decompression of Guyon's canal?
So I think it's, I guess, to complete the discussion. The textbook stuff talks about if you're doing a Guyon's canal release, sometimes you have to worry about compressive masses and cysts, et cetera. And then we'll talk about the hook of the hamate too, because that, depending on where the mass or the fracture is, that could depend on what your sensory or motor deficit is, whether it's combined, whether it's sensory only, weakness only, et cetera. Um, I think the biggest other technical pearls are just recognizing that your ADM branch is going to be heading in a different direction than your deep ulnar motor branch. I think that some people will say that you can't see your deep ulnar motor branch until you've actually decompressed it. I actually think that you can if you work at it. And the way that I've, for a few years now, if you dissect your ulnar artery adjacent to your ulnar nerve in the palm, you will see kind of a transverse branch that pretty classically comes off, um, you know, heading towards the skin overlying the hypothenars. And that transverse branch tends to be where the ulnar nerve starts to split and bifurcate. So that branch is kind of coming like this. So it's like that. It's on top of it. It's not in between. But when you see that branch in the ulnar artery, then I know to spread underneath the ulnar nerve and then visualize that bifurcation. And in most patients, that if you do that, you can actually see zone two or the deep motor branch before it goes into quote zone two proper. And as much as like sometimes you just got to release that fascia and just see the nerve then, but I feel much better, especially if I'm training somebody, to find the nerve to show it to them before I start doing the decompression. That's probably the biggest thing that I've picked up on, in the last few years is just doing that. And then I think that, you want to minimize the trauma to the muscle, but you want to do the release. I don't feel a strong need to visualize all the way to the end, but you got to make sure that you release the underlying deep fascia because there's that deep fascial band that can really be compressive. And if you haven't fully released that and felt, and if you can't see it, but ideally just see it, but sometimes you just feel it, that's completely decompressed. You got to get that deep fascia. And then like you can do your, if you're doing your supercharged nerve transfer, which is a different conversation altogether, you can then get your jump on neuralizing that motor branch off of the rest of the ulnar nerve.
Yeah, different episode for sure. So when you work around the hook of the hamate and approach the piezo hamate hiatus, where the deep motor branch is curving around the hook of the hamate to head radially deep in the palm, do you just make sure there's enough room? Do you cut some of the supporting structures to give more room for that motor branch? How do you think about that?
I don't think you need to cut any of the supporting structures aside from releasing the deep fascia underneath the hypothenars. I don't think you need more than that. I haven't done the volume of hook of hamate excisions where there may be alterations in morphology of those structures because of injury or trauma or repetitive use. But at least in my population, I don't feel the need to do that, which is a good segue into hook of hamate fractures. So
I think
what's
this
your latest technical observations on hook of hamate fracture treatment, both from indications as well as doing the actual surgery.
I'm gonna make 3 points. I'm hoping I can actually make 3 points, but I'm gonna say I'm gonna make
This
three
is one
points.
more than your usual.
Yes. The first point is more and more, if one has a hook of the hamate, whether they're a baseball player and it's their non-dominant hand, their kind of bottom hand on the bat, or an older patient who has a fall. I don't believe in casting these for the vast majority of patients. Almost everyone gets a surgery to take out the hook of the hamate because healing at that poorly vascularized hook to body zone is poor. So, number one, almost everyone gets a hook of the hamate excision. Is
So
that
what's the timing of that for you? Because that's different than textbook, right? So
I think textbooks are evolving that way
it's because
because our
you write them.
well, thank you. Not really. Because I think people are not willing to be casted for 8 weeks and then reassessed and maybe then have surgery. But I think they don't. My experience is they don't heal and they don't heal rapidly for sure. So I will always give that option. But if they ask me what I would do if they were in my family, I'd say do the small surgery and take out the hook of the hamate. So that's number one.
Okay.
And there's no role for fixation. There's zero role for screws in the hook of the hamate or anything like
And
that.
again, we're talking about hook fractures, not body fractures.
Hook fractures, yes, exactly.
Does it even
So
matter the size of the piece? What if it's a huge piece that could take a nice little screw?
don't do it. Resist the urge. Resist the orthopedic urge.
So
Number,
no casting whatsoever. Do you give them a trial of non-op just to see like, hey, like what if this feels better? Like even if you're not casting, say you just put them in a brace or an ace wrap and just say, it might spare your surgery.
I guess it captures how I have these conversations. I will list the options, cast, brace, surgery, and I will go through why I think each can make sense and might be for them and or doesn't make sense. So yeah, it's an option. I just don't think it makes any sense.
It's really interesting how much who you work with will shape how you approach things and our different styles of talking to patients. Because I know that there are a couple of our partners who would definitely try to not try, but in an appropriate and concerning and empathic way, probably steer the patients one way or the other. I remember a former partner of ours who now practices elsewhere, and I was working with them in fellowship, and I was like, "Well, how do you kind of tell them about this, that, or the other?" Like, I think it was dystorated stuff. He's like, "Listen, I give them options, just kind of like you did." I was like, "I definitely know where he picked that up from."
Yeah, and the older I get, the less, I guess, not invested is the wrong word, the less dogmatic I feel about they must choose this. Now, the way I talk about it may guide them whether I'm intending to or not, but patients choose different things for different reasons. I think the less we push and the more we help them come to the right decision for them, the better.
I think there was a line that I heard that I think that came off one of the new medical series, but it was, I give my recommendations, you make decisions.
I, I,
And I gave a recommendation the other day in clinic that I thought was very appropriate for a potential malignancy, and this patient said no. I said okay.
okay. Yeah. What else are you going to say? Surgically, it's kind of just what you said. Longitudinal incision, beginning at the wrist crease, heading distally, find the nerve and artery, because often they sit right on top of the hook. And the hook is palpable, and just mobilize those carefully. And then I typically use sharp dissection around the hook. And a displaced fracture is far easier to take out than a fracture that's either minimally or non-displaced, and I remove it and I try to do it elegantly, uh, and then remove it in mass, but also don't mind taking it out differently if it doesn't seem to want to come out easily.
Is that fracture line sometimes harder to find in a non-acute setting? I mean, so and then how do you find it? Is it just kind of get a rongeur on the hook and just kind of wiggle it and see where you can slide a free in or something like that? Or
Yeah, I think it can be hard to find, and sometimes I'll put a little osteotome there, or I'll put a freer there to try to, develop that plane. Sometimes it's very easy, and those are the ones where the, case doesn't take long. Other times you're just trying to find the hook body intersection, to then remove the hook and then smooth those borders.
because yeah, not exactly an easy floor scan image to take, when you're trying to get an instrument in there and get a really nice view of the hook and try to get, visualize where the fracture line is.
Yeah, and I don't use a floor scan at all. I don't have it. I don't have a drape for it. I mean, you can. It's just awkward. It's very awkward to your point.
Say you excise the piece. You talked about smoothing the bone edges. What are you doing for that to actually technically execute that part of the procedure?
Yeah, rongeur, just so that there's, we know that if you don't treat a displaced hook of the hamate fracture, eventually the tendons will be affected to the ring and little finger as they curve around the hook. And so I don't want that happening because I didn't smooth the edges. And I think that is easily done, and you have to keep track of both zone two and zone three, so the motor and sensory portion of the ulnar nerve during that process.
I like a little rasp in that area. I don't know if it's always available
Rasp.
everywhere, but
Crazy.
nice little the rasp at the very tip. It's lovely.
Ah, it's
Any
elegant.
any bone wax?
I will often put a little bone wax in there, and it's such a minuscule amount. You hate to waste all that bone wax, but
It makes me feel better. I don't know. I probably should learn how long that stuff lasts, what happens to it, and everything. But I know it's so common with what we do in other orthopedic things that I don't even think twice about it. But I don't know. It makes me feel better that I rasp the edges and I put a little bone wax on the cancellous surface.
one thing I've learned is that I always splint these patients for 2 weeks. And they don't need to be splinted. We're not protecting anything, but with early motion of the wrist after the hook of the hamate fracture seems to cause a lot of discomfort. So I splint them for 2 weeks. They come back after hook of the hamate excision, and then I leave it up to them how they ramp up, often for baseball. And I've had people go back and play at 3 weeks. But my line, based on a study we did here, and other studies have found similar time frames, is 6 weeks is the average return to play.
Okay. Well, those are the questions everybody wants to know. Can you remind me one more time? You've taught me, educated me about this, but I've never really picked it up. You've taught me that it's the bottom hand of the bat. Why is it the bottom hand?
Thank you. I love this question. I love talking about it with families. It is always the bottom hand because as you swing through, so if you're right-handed, throw right, bat right. Your left hand's on the bottom of the bat, which is 90% of the population. And as you swing through the bat, all the forces of the bat are directly over the hook of the hamate. And there actually are bat modifications that exist that change that load bearing of the back, which would prevent this from happening. It's really super interesting. And I consulted with a company, not for any reimbursement, when they were developing this bat. No one wants a funky bat because no one, if you break your hook with a hamate, you fix it and it's done. And
You don't
so,
fix it. You don't fix it.
well,
You
you
excise it.
address it, you excise it. Correct. Anyways, it's
Now,
interesting.
you know
But
what's going to happen is that there's probably like a basement full of these things in your office, or of these devices that you've hoarded because you don't want anybody to have them because you love treating this
that's
condition so
right.
much.
That's right.
You see it with, it's probably different, but I mean, other sports of it with like cricket or lacrosse. Like, would you see this with that? But you don't have that same repetitive loading in that manner.
You can see them, and obviously I'm less familiar with cricket. I don't know that I've seen it in a lacrosse player. I've seen it in a
Hockey?
tennis. Hockey can theoretically do it. Tennis can theoretically do it, but 98% of my patients, at least, are baseball with a smattering of falls.
Okay. Well, I mean, I'm learning more about tennis, but if you hit a proper two-handed backhand, you shouldn't be loading the racket in
You
that
should not.
area. But
You should not.
maybe we should consult some of our better tennis playing partners.
Yes.
Anyway, thank you. If you've made it this far, this was a long episode because I just kind of nerded out about the nerve there. But if you made it this far, if you have other questions you want to submit to us, handpodcast@gmail.com. It certainly helps us come up with ideas for episodes. So thank you for emailing any topic suggestions you have. And if there are guests that you want to hear from, please let us know because Chuck is very important and famous and can get pretty much anybody on this podcast.
Yeah, we do need a guest. I would like to have a guest. I'm tired of talking to you one on one. I'd like to have a guest.
Fair enough. So the call is out there. The mandate has been issued. Please let us know.
All right. Have a good one.
You too.